Hello, I'm back. This is Rockson Liu, dedicated hernia surgeon in Emeryville, California. So last video I talked about the small umbilical ventral hernia. And I'll continue on the topic of ventral hernias and talk about medium-sized hernia. So medium-sized hernia, everybody defines it a little differently, but I would say once your hernia gets above like 2 to 3 centimeters, it is a different hernia. Okay, the physics, the mechanics with these slightly larger hernias are different and requires a different approach. So I think 3 centimeters or bigger should, patients with that size hernia should probably have a robotic approach. Open approaches are still good, and laparoscopic approaches are good, but we're starting to talk about maybe more pain with recovery, more chance of recurrence with the traditional approaches. And so I think robotic surgery is probably the best approach that we have nowadays. Now, there's a lot for me to cover here, and I sometimes get into some very technical stuff that maybe wouldn't benefit you. So excuse me if I do that, but I just love talking about hernias, and there's just so much for me to say. But number one is, with ventral hernia surgery, again, I showed you the different meshes, but I just found this other mesh, which I forgot I had. This is a Ventral X mesh, which has a coating. This pink thing, it's a coating. It's a collagen barrier. You can see how it's rubbing off here, but it's designed to prevent your intestines and your bowel from sticking to it. But I can tell you there's no coating that's perfect. There's a reason why there are hundreds of meshes out there, because everybody thinks they have a better coating and they're marketed as that. But I've gone back into the belly and so many patients who have had these meshes with coating, and there's almost always something stuck to it. Now, occasionally there's nothing stuck to it, but more often than not, the intestines are stuck to it. As a general surgeon, I can tell you, I hate going back into the abdomen in somebody who's had one of these IPOM or coated meshes placed into the belly, because I just know there's going to be adhesions. Now, this is a pretty small one. This one I would probably use it to fix a 3 centimeter defect. But you can imagine there are some really big ones that we can use, and if their entire abdominal cavity, abdominal wall is lined with this, it's going to be really hard for me to get in without potentially injuring your intestine if you need additional surgery like gallbladder surgery, appendix surgery, prostate surgery, hysterectomy, or colon surgery. If you have this piece of mesh in, it would be very hard. So the larger defects, I like to use again this Priatine, right? This is a lightweight mesh. You can barely feel it. In fact, I've had surgeons operate through my patients who have had this mesh, and they didn't even notice that there was mesh there, because it's so lightweight, and it kind of disappears into your tissue. Again, what I like about this is, I mentioned this in the last video, is that the techniques I have now, the preperitoneal mesh, the ETEP, retrorectus, or reef stopa techniques, I put this mesh in a pocket, and then it gets sandwiched between layers, so it has nowhere to go. And it's a very solid repair. And it benefits from not having mesh inside the abdominal cavity where it's touching bowel, right? So you'll hear the terms TAP, transabdominal preperitoneal. You'll hear ETEP, extended view, totally extraperitoneal surgery, ETEP reef stopa, ETEP retrorectus. You'll start hearing about single port TEP, single port square ETEP. There's all kinds of acronyms. It gets really confusing, and even hernia surgeons get confused about these acronyms. So don't worry about it. But just know that with the robotic technique, it's easier to place the mesh in this extraperitoneal plane using this kind of mesh that doesn't require IPOM. And as I mentioned earlier, to develop the what we call the flap, the peritoneal flap or the retrorectus flap, it requires a lot of skill and technique, and it's hard surgery. But when your hernia gets from 3 centimeters and greater, go up to 15 centimeters. 3 centimeters greater, I think that the robotic repair is better, just because I can get a good sized piece of mesh in the right size mesh, and then in that preperitoneal space. Now with the open surgery, if I'm working through a hole about this big, it's very hard for me to get a good sized piece of mesh in. And I honestly believe that the recurrence rate has been, measurable, right? Meaning not zero, because through this little hole, it's very hard to tuck a good sized piece of mesh in, right? And so your overlap is not adequate, or the mesh kind of gets shriveled up in that little pocket, and then so it can't extend out flat, and so the recurrence rate is higher. Laparoscopically, again, the IPOM with the need for fixation it has weakness in the middle, and it's a very painful operation because you can imagine using all those stitches to hold the mesh in place, grabbing the muscle, potentially hitting the nerves that are traveling in the space, in the retrorectus space, can lead to a lot of pain. When I used to do it, because I didn't have access to a robot, I was prescribing people OxyContin because they were on narcotics for months. And so I was feeding that OxyContin machine. So Purdue Pharma, made some money off of me. But I don't offer that operation now because it's just too painful with all those fixation points. So I think state-of-the-art operation is the robotic TAP or ETEP, reef stolpa repair. And again, you need a very good skilled surgeon to perform those operations. Otherwise, it's going to get converted to an IPOM. And then you're going to end up with the same results as what we used to get with the laparoscopic and open surgery. So thank you for watching. I'll be back soon.